So today we will be learning about the immune thrombocytopenia. This is a very simple and easy topic. We will start with what it means. Immune means it is related to the immune system. So thrombocyto stands for platelets and penia means decrease. So there is a decrease in the number of platelets due to some immune process. So let us understand what is this immune process. Your spleen starts to make these antibodies which will attach to the platelets. The platelets get taken up by the macrophages of the spleen and they get destroyed. So the spleen is doing two things here. First thing that it is doing is that it is making those IgG antibodies against the surface of the platelet. And the second thing that it is doing is that it takes up those antibody bound platelets and it destroys them. So basically there are two types of immune thrombocytopenia. The first type is acute form and the second type is a chronic form. As you know, acute is going to be something which resolves relatively quickly. If somebody develops immune thrombocytopenia and it resolves within 3 months, then they have something called the acute form of the disease. So it will resolve within weeks of presentation. Chronic form, there will be thrombocytopenia and it will persist for more than 1 year. So you have the acute form and the chronic form. The acute form is basically present in the children and it happens after some viral infection or immunization, and that can trigger a spleen to make these antibodies, and that can cause this acute form of the disease which will itself resolve within a few weeks. In the chronic form, however, patients usually are adults and usually it is women of childbearing age, and it can be either primary or secondary. So primary is going to be idiopathic, we don't know what causes it, but it can also develop secondary to some known cause. And this is important for us to know because when we are treating immune thrombocytopenic purpura, if it is secondary to some cause, we need to treat that cause. So secondary to infections or secondary to other autoimmune disorders which the female is already having. So what can be the other infections? They can be if the patient is already having HIV or hepatitis C or CMV infection, they can concurrently develop immune thrombocytopenic purpura. Or if they were already having like lupus or any thyroid disease, they can also develop concurrent immune thrombocytopenic purpura, and that will be the chronic form of the disease. So what we have talked up till now is that basically immune thrombocytopenia is a decrease in the number of platelet due to the formation of antibodies which is coming from the spleen, and it has two forms. It has acute form and chronic form. The acute form resolves quickly. It happens in children usually after a viral infection or immunization. The chronic form will persist for more than 1 year and it usually happens in adults, usually women, and it can be primary, we do not know the cause, or it can be secondary to some known infection or autoimmune process. Now, what are the clinical findings? The clinical findings that you will get are the findings due to thrombocytopenia. So, whenever there is a decrease in the platelet count in the blood, you can get petechiae or ecchymosis or mucosal bleeding. So, the concept basically here is that whenever you have some type of damage to the blood vessel, the first thing that happens is the formation of a primary platelet plug. After the formation of a primary platelet plug, you will activate the coagulation cascade and that will form this fibrin cross links and that will form your actual clot that stops the bleeding from the site. So platelets have a very important function in forming the primary platelet plug. Now what happens when you are unable to form that plug? So you start to get these bleeding spots which can be cutaneous or they can be mucosal. This is also a very important differentiating factor between bleeding which you get from deficiency of platelets versus bleeding which you get from deficiency of some coagulation factor like factor A in hemophilias, for example. So the main differentiating point is with platelet dysfunction you will get cutaneous or mucosal bleeds. With coagulation factor deficiencies, you will get deep tissue bleeds, like bleeding into the joints, for example. So with platelets, you will get either petechiae or ecchymosis. The difference between petechiae and ecchymosis is just the size of the spot on the skin. And the mucosal bleed, if it is from the nasal mucosa, it will be epistaxis. If it is from the mucosa of the urinary bladder, it will become hematuria, and so on and so forth. So what are the lab findings that we can find in immune thrombocytopenic purpura? First and foremost, you will find isolated thrombocytopenia. Isolated because the rest of the labs will be completely normal and fine. The only finding that you will get is the low platelet count. Secondly, if you perform the peripheral smear, you will find that the platelets are less in number, but they are normal. And if you perform the bone marrow biopsy, you will see the increased megakaryocytes. So the concept here is that the megakaryocytes are the cells which make the platelets. Platelets are simply fragments of the megakaryocyte. So when you have low platelets in blood, so this is going to cause the megakaryocytes to increase in the bone marrow. We usually do not confirm thrombocytopenia with a bone marrow biopsy, but if you do so, you will find increased megakaryocytes. And the last point here is normal PT and PTT. So PT and PTT basically show the coagulation cascade. And since the coagulation cascade is completely normal, you get normal values of PT and PTT. The only finding that you get is an isolated thrombocytopenia. Treatment, the first thing that you want to do is observe the child. If the only finding in the labs is a thrombocytopenia but the child has no symptoms at all, or if the child has thrombocytopenia and has cutaneous symptoms only, which are going to be petechiae and ecchymosis, then you can simply observe and you do not need to treat it with anything, because as you know, in children it is usually the acute form and it will resolve itself with time. If the child is experiencing some kind of bleeding episodes, if there is a recurrent episode of bleeding, then you can treat with glucocorticoids, IVIG or anti-D. So what is the concept of using glucocorticoids? It is because the immune system is producing these autoantibodies that you are getting this disease. You want to inhibit the immune system and you can do that by giving corticosteroids. The second thing that you can do is give IVIG. So IVIG is basically IV immunoglobulin. As we recall that the actual pathology was this antibody which was formed against the platelets. So what we do is we give antibodies from outside and the splenic macrophages become busy with those antibodies, so they are unable to remove the antibodies which are bound to the platelets, and so the platelets are spared, so you don't get thrombocytopenia. So that is the concept of IVIG. And the last treatment that we use is anti-D. They have these blood groups which can be either ABO, or they can have these blood groups which can be classified as RH antigen. So the RH antigen can be present on the RBC or it can be absent on the RBC. If the patient is RH positive, you can give the anti-D immunoglobulin and it will go and bind to the RBCs, and now the macrophages in the spleen will become busy with these RBCs and these antibodies which are bound to the RBCs, so the platelets will be spared. If the patient is not having an RH antigen, you cannot use this therapy. So these are the three therapies. You can use glucocorticoids as it inhibits the immune system. You can use the IVIG as it engages the macrophages and so the platelets are spared. And you can use the anti-D, but only if the patient is Rh positive. Treatment in adults is also observation if the adult has thrombocytopenia on the labs and has only cutaneous symptoms like petechiae and purpura. If the adult has platelet count which is equal to or greater than 30,000, you can also observe. So we have a cutoff of 30,000 in the adults. As we know that in children it is usually a self-limited disease and they usually have the acute form, so we don't need to follow up with the platelets. But in adults it is usually chronic and persists greater than 1 year, so we need to follow up with the platelets. And if the platelet count is 30,000 or more, we can simply observe the patient. However, if the platelet count drops below 30,000, then we need to give some kind of treatment. And you can treat with glucocorticoids, IVIG and anti-D as I explained previously if the adult is symptomatic, is having recurrent bleeding episodes or having platelet count which is less than 30,000. And finally, we come to the second line therapies. So you gave them glucocorticoids and IVIG and anti-D, but none of it worked. And now you need to look towards the second line therapy. So one of the therapies is a splenectomy. So splenectomy is very easy to understand in this scenario because spleen is the organ which is generating the antibodies, and spleen is the organ which is removing the platelets. So if you remove the spleen, you will no longer generate the autoantibodies, and you will also not remove the platelets, so you will not get thrombocytopenia. However, there are certain risks involved with splenectomy. Of obviously there is going to be increased risk of infection with encapsulated organisms because spleen plays a very important role in removing encapsulated organisms from the body. Other second line therapies are rituximab and thrombopoietin receptor agonists. So basically, rituximab inhibits the B cell, and the B cell forms the plasma cell, and the plasma cell forms the antibody. So basically, what you are doing is you inhibit the cell which is responsible for formation of the antibodies by giving rituximab. The other drug is thrombopoietin receptor agonist. What happens is that you have this substance which is thrombopoietin, which is being produced in the body, and it goes and causes the megakaryocytes in the bone marrow to produce more platelets. You can give this thrombopoietin receptor agonist, which is going to go and bind to the megakaryocytes and cause increased production of the platelets. That's all from my side. If you have any questions, please feel free to ask them in the comments. Thank you.